ABG interpretation case study Aglan protocol. How to study ABG? 4 items. Number 1, listen carefully to the clinical history. Number 2, study the lab investigations including the ABG chart. Number 3, look at this Aglan ABG table to fill in the spaces measured and calculated. Number 4, back to this Aglan ABG table to study pH, chloride items, bicarbonate items, oxygenation state of the lung, and ventilation state of the lung. Clinical history. Study of the clinical history will be important for 2 things. Number 1, to anticipate the pathophysiology. Number 2, to anticipate the sequelae of events. Anticipation of the pathophysiology, like what? If the patient is vomiting, is going to lose chloride, gain bicarbonate, to develop hypochloremic metabolic alkalosis. If the patient develops diarrhea, will lose bicarbonate, gain chloride, to develop hyperchloremic metabolic acidosis. If the patient develops diabetic ketoacidosis, bicarbonate will be consumed, so he will develop high anion gap metabolic acidosis. In a renal failure patient, bicarbonate will be consumed by the fixed acids to develop also high anion gap metabolic acidosis. Methyl intoxication will be associated with the formation of formic acid to consume bicarbonate to develop high anion gap metabolic acidosis. Stable congestive heart failure, the patient will have hyponatremia, maybe on diuretics like furosemide to develop hypokalemic metabolic alkalosis. Liver cirrhosis patient will have hyponatremia, hypoalbuminemia, hypokalemia, and develop metabolic alkalosis. Anticipation of the sequelae of events, like what? If the patient develops vomiting, then became shocked, vomiting will develop hypochloremic metabolic alkalosis, then shock will develop high anion gap metabolic acidosis. Lab investigations you should study sodium, chloride, potassium, BUN, serum creatinine, random blood sugar, ketone bodies, and serum lactate. Then come to the ABG chart to study it, to see the values. For the calculations of the calculated items, don't forget these formulas, these equations. I collected it in the form of golden rule in these 4 slides. You should know it by heart. Number 3, look at the Aglan table and fill the spaces. These spaces are 2. Number 1, the measured items will be taken from the lab investigation and the ABG chart. Then the calculated items with these red arrows, you have to calculate it before starting the Aglan ABG table. Number 4, study Aglan table. This Aglan table, as I have mentioned before, is formed of measured values and calculated values. To start with, number 1, by the pH. Number 2, the chloride items. Chloride items, serum chloride, chloride sodium ratio, corrected bicarbonate, and strong ion difference. Number 3, bicarbonate items, serum bicarbonate, anion gap, buffer base, strong ion gap, base excess. Number 4, oxygenation state of the lung, FiO2, BO2, B arterial oxygen, Bishop oxygen of arterial oxygen, and alveolar arterial gradient. Number 5, ventilation state, the Bishop carbon dioxide and its relation to the pH and bicarbonate. To study the pH, for sure, see whether is it normal, acidemia, or alkalemia. Start studying the chloride atoms number 2. As I've mentioned before, serum chloride, chloride sodium ratio, anion gap, strong ion differences, and corrected bicarbonate. From these items and from these data, you will come to the diagnosis of the start diagnosis, start pathology, the first pathology. Number 3, studying bicarbonate items, serum bicarbonate, buffer base, phase excess, strong ion gap, and anion gap. This will give you the last or the second pathology and the second diagnosis. Number 4, the oxygenation state of the lung will be studied through studying FiO2 and BaO2, and you will come to the formula alveolar arterial gradient to diagnose the oxygenation state. Is it normal or hypoxic? Number 5, studying the ventilation state through studying the partial Bishop carbon dioxide correlated with bicarbonate and pH. See whether the patient is hypoventilated, hyperventilated, normoventilated, compensated, or not. Case number 7. A 50-year-old insulin-dependent diabetic woman was brought to the emergency department by ambulance. She was semi-comatose and had been ill for several days. Current medication was digoxin and thiazide diuretics for congestive heart failure. From this history, I have two pathology. Number 1, this stable state of this case was congestive heart failure and shows diabetic, but most probably some sort of problem happens with diabetes to be semi-comatose. Let's come to the investigation. Sodium on 32, potassium low 2.7, chloride low 79, glucose 815, lactate 0.9, urine ketones 3 pluses, pH 7.4, partial Bishop carbon dioxide 32, bicarbonate 19, partial Bishop oxygen 82. She was on room air. Let's come and study the Aglan ABG table. This is the actual state of the patient. pH is 7.4, carbon dioxide 32, and bicarbonate 19. This is metabolic acidosis with compensatory respiratory alkalosis, and the pH is 7.4. If you calculate it like that, the drop of bicarbonate from 24 to 19, the compensations will be this value. So this is number 1, the pH. This is metabolic acidosis with compensatory respiratory alkalosis. Let's come to the second item, which is chloride. Chloride 79 is low. Chloride to sodium is very low. Instead of being 74%, it is 60%. So this is hypochloremia. Come to the strong ion differences. Hypochloremic is more than 40, metabolic alkalosis. And when you come to the corrected bicarbonate, it's very high, 41. So it is clear that the stable state when this patient with a congestive heart failure, with hypokalemia, and on thiazides, this will stimulate carbonic anhydrase, so there is excessive production of bicarbonate and loss of chloride. So this is this previous state: hypochloremic, metabolic alkalosis 41, strong and difference more than 40. And when you measure the anion gap in this state, is 12. So this is a true hypochloremic metabolic alkalosis normal anion gap. And this bicarbonate will result in carbon dioxide if you calculate it from the formula 48, and the effect of carbon dioxide and bicarbonate will produce this pH. So this is a pretty good state of this patient. When you come to the buffer base, for sure 41 plus 16, this will give you the buffer base 57. Strong ion gap, no fixed acid is added in this case, in this state, and the base excess, it is base excess 16. So this is the state of the patient with congestive heart failure, on-thiazide, and hypokalemia. What happens? This patient is diabetic, insulin dependent, and her blood sugar was very high, and they developed the diabetic ketoacidosis. So the bicarbonate dropped from 41 to 19. So this is the metabolic acidosis. With what about high anion gap? Oh, anion gap is 34. So this is a high anion gap metabolic acidosis. When you come to the strong ion difference, it is no change in sodium and chloride, so it is the previous one. Buffer base dropped from 37 to 35, so the buffer base is low, and the base excess here, this base deficit for sure. This is 19, and this is the normal pH. So 24 minus 19 will give you minus 5. This is the base deficit. To change it from base excess to base deficit, from normal anion gap to high anion gap metabolic acidosis, and the fixed acid has been added, so the strong ion gap from 0 to 22. So the patient, first she has hypochloremic metabolic alkalosis, and then developed the high anion gap metabolic acidosis. What about the oxidation state? She was on room air. We calculate alveolar partial pressure of oxygen 107. They measure the arterial oxygen 82, and alveolar arterial gradient 25. It's a little bit high. Is due to most probably due to lung pathology and the form of interstitial edema. What about the ventilation state? Is good. Good. This is a compensation to the metabolic acidosis. Good compensation to the metabolic acidosis. So the final diagnosis is that this patient had hypochloremic metabolic alkalosis with normal anion gap, and developed high anion gap metabolic acidosis with normal respiratory system. Thank you.